My name is Collins Uzuegbu. I'm a CNS, clinical nurse specialist with Cleveland Clinic Palliative Medicine Service.
The left.
To the left.
Yeah, the mic.
Thank you. I said, my name is Collins Uzuegbu. I'm a CNS with Palliative Medicine at the Cleveland Clinic. I'll be talking about the impact of climate change on the practice of hospice and palliative medicine, a scope and review. I just wanted to thank the organizers, Dr. Gordon and the rest of the team for having me here. I usually like to start my presentations with a joke. So bear with me after the big lunch. I just wanted to tell a little. There was this story about a patient who went to see his primary care physician because he had burn injuries to both ears. And so the doctor was like, what happened? How do you burn your ears? He goes, I was ironing my shirt and my phone rang and I picked up the iron instead of the phone. And he goes, what happened to the other ear? He goes, they called back. So I'm hoping that, while we're here is so we don't repeat the mistakes of the past. And so we start to correct all the mistakes and errors of the past that put us in the predicament that we're in with climate change. I like this quote in particular in front of my slide here. The provision of palliative care in the context of a disaster with scarce resources can be considered a moral imperative of a humane society. This was from IOM's Crisis Standards of Care in 2012. And I'll be talking a little bit more about this as I go on in the presentation. This is our amazing team. There are 7 of us. We'll have multiple countries represented here, working out of 3 time zones. And so our meetings were often quite difficult for some of us because they're either coming home from work or it's in the middle of the night. And so this picture right here just reminded me one day that I was watching the Weather Channel, and the news, the weather newscaster person was like, "This is Mother Nature, so angry, lost their mind, and look at all the snow." And I went, this is not Mother Nature. We actually made Mother Nature lose her mind. We fed her all the toxins and so forth with the environment. And so here's my outline. I'm not going to be going into reading all of them, but as most of the presenters that came before me had talked about, I start with my introduction, go over methods and our themes, and then go over gaps and future directions regarding the impact of climate change on our practice. And our learning objectives will be covering just a description of some of the experiences of my colleagues from around the world as they practice palliative medicine in the midst of the climate disasters that we're all dealing with. I will also be going over a review of research on climate change and palliative care. And then, of course, we'll consider next steps and future directions of research in the area. So before I talk about this, I just want to make sure that everybody in the room and everyone else listening knows what palliative care is. I've been in the practice of palliative medicine going on 15 years now, and it doesn't happen as often, but in the beginning, I find that when I'm consulted to see a patient for symptom management, the first question is often, why are you here? I'm not dying. I don't need you. Well, palliative care is for people who are not dying. Seriously, it is for people who have serious illness and have a lot of symptom burdens and are looking to improve their symptoms so that they can continue treatment either to cure their diseases or to modify the treatment course. And it's to improve the quality of life of the patient. It is to support the family as well. And it can happen at any stage of the disease. And it continues. Now, the end of palliative care along the disease continuum is hospice. And that's where, for those of us here in the US, where Medicare defines hospice as, or defines a hospice patient as one who has a prognosis of 6 months or less to live. So for our methods, research question obviously is looking into evidence regarding the impact of climate change on our practice field. Our search strategy included databases such as Medline, Embase, Web of Science, and Cochrane. We use climate change terms such as climate change, climate disaster, and so forth. And for palliative care terms, covered even hospice, terminal ill patients, advanced care planning, end of life, and so forth. For our consort diagram, we saw 634 articles. Now, that pales in comparison to a few others that were in the thousands. We saw a lot of duplicates, which were removed. The title and abstracts that were screened were 382. We took out 341. Full text that we assessed was 41, and we took out about 21 because they didn't discuss climate change. Some didn't talk about hospice and palliative medicine at all, and we ultimately included 20 articles for our final analysis. So the themes under which we organized the articles, starting with just disaster response, going over recommendations and frameworks with regards to disaster response. So some of the articles essentially sets the expectation that all patients, regardless of availability of resources, deserve care. They deserve to receive good care, which also includes palliative and hospice care. And again, this is a reference to the moral imperative that I talked about in my first slide. And the articles also supported palliative care surge capacity to be very important across all settings. That includes with staff training and even common medications that we use for symptom management. Unfortunately, with all this disaster planning, palliative care team or palliative care specialists are often not included in this planning. It was encouraging to see in some of the literatures that they used lessons learned from previous disasters to develop a comprehensive emergency management plan. But those often apply to in-home healthcare. But being a palliative medicine specialist, I find that some of those recommendations could also be used by in-home hospices. And then there's a recommendation for hazard vulnerability analysis that should be followed by a mitigation plan. An example would be having a patient that is oxygen dependent on the priority list of a utility company, so that after a disaster and light is out, they can have their power restored before everyone else. And then there's strong recommendation for collaboration between spiritual care and mental health colleagues. The next theme that we looked at was the impact of climate change on hospice and palliative medicine in low-resource countries. Some of the things that we saw in the literature included increased flooding, drought, low crop yield, community displacement, worsening of food security, which we found disproportionately affected people in end-of-life situations, especially women. Undernourished palliative care patients often are prone to increased morbidity, especially from infectious diseases such as HIV. And then this particular Malawi study referenced the difficulty with low nurse-to-patient ratio. I think the number was like 0.2 to 1,000 people compared to 7.9, say, in England. And this low nurse-to-patient ratio required family members who are already working more and getting less from their farms to be at the bedside as primary caregivers for the patient, which in turn worsens poverty, which in turn worsens the nutritional status of the patient, which of course worsens their overall health status. We also found that climate change breaks the community cohesion, worsening poverty in the community, and of course reduces the network of caregivers that people in end of life often relied on. The next theme we considered was some descriptive pieces on climate change, climate disasters, and it affects hospice and palliative medicine. The most common articles that we saw were short and descriptive in nature. They're often by hospice and palliative medicine providers who were essentially discussing their experiences after having gone through climate disasters. The recommendations across the board was to have palliative care measures and palliative care team as part of the disaster and triage planning. And then there's also some descriptions of challenges in reaching patients following disasters. Somebody said something like driving through streets with downed trees and wires. And then there are cases of patients who are not able to make it to the palliative care clinics just because of all the damages, infrastructure damages following the disaster. And then the hospice and palliative medicine professionals, I hear someone else during their presentation mention just the amount of suffering and pain and the burdens that caregivers like ourselves experience after these disasters. And these palliative medicine professionals spoke to that, felt like they were overstretched, out of place, and oftentimes found themselves in boat rescues and driving through downed trees, rescuing their patients before providing palliative care to the patients, which is quite not any one of us were trained to do. And then the seriously ill patients, if you've ever been in the midst of a disaster, we know that, they have these long lines where you have to wait your turns to get aid. Well, how are you going to do that for a patient with stage 4 cancer who has extreme pain because of spinal metastasis? They can't stand in line. What do you do? And these are some of the descriptive pieces that we saw refer to this, that these patients are just never able to access those aids. And then there's some long-term loss of healthcare resources. This particular Florida study mentioned the loss of hospital access, even up to 7 months following hurricane. And then the loss of mental health facilities many months after the disaster. So, it's quite common to say after these disasters, you get mental health care, which we all should encourage. But when you don't have those facilities, that's a problem. And then there's some mention of euthanasia, excuse me, during disasters. And one that comes to mind is the case of Dr. Paul. If you guys will remember, after Hurricane Katrina, the question of administering excessive doses of opioids and benzos that led to the death of a patient. I mean, for us in palliative care, our experience has been that when you provide excellent symptom management, the question of euthanasia becomes mute. Frankly, most patients don't ask for it if you provide excellent specialty-based clinical symptom management. There's also strong recommendations for climate disaster preparedness to include training, routine training for hospitals. And then, of course, again, the role of palliative medicine in helping triage these cases and manage symptoms. And oftentimes we use certain medications. For us in palliative and hospice ward, we call them dirty drugs, the morphines, the old antipsychotics and so forth to manage symptoms, which are often misconceived as resulting to the death of the patient. But we do know that when you titrate these medications right, following standard guidelines, people often do quite well, having well-managed symptoms and live out their lives for as long as their diseases allow them. And then the next theme we talked about was mortality and morbidity after climate disasters. The studies highlighted the horrors of climate disasters in our patient population. One large retrospective study showed increase in mortality of nursing home residents, both hospice enrolled and non-hospice enrolled patients following a hurricane. There's also increased mortality of hospice patients, in particular, that were threefold following months after hurricane. Non-hospice residents, on the other hand, did see higher mortality 90 days after the disaster. Again, just highlighting the importance of early hospice enrollment in these patients. And just like it's been mentioned in previous presentations, that dementia patients do see rapid progression of their diseases and also suffer a lot of traumas following these disasters. And we did look a little bit at carbon footprint of hospice. One hospice with 16-unit bed in the UK that we looked at had about 420 tons kg CO2 emission. By comparison, that's more than 10 times what a single individual emits in the UK, and cataract surgery consumes about 405. In this same study, there was strong interest from the hospice and palliative medicine providers on just sustainability. So, like I was telling you at the beginning of this, I did mention that because the articles that we looked at were so few, we reached out to fellow professionals from other countries to go over just their lived experiences, and we were able to get some very, very important information from them. When we talked to people from Japan, to the Philippines, to Saudi Arabia, Nigeria, Sierra Leone, and so forth. Floods, storms, droughts, and heat waves are often the common disasters that they identified. Wildfires led to interruptions in standard of care for the seriously ill patients. Damage from climate disasters also affected infrastructures. One Sierra Leonean physician who also practices palliative medicine mentioned to me that, you know, when they have these massive storms and lose electricity, in her community hospital, they would often transfer patients to more affluent private hospitals. I mean, affluence in Sierra Leone, which is one of the poorest countries in the world, often doesn't go hand in hand. So she says that a lot of times they left those patients basically to their fate, and they do lose quite a few people after these incidents. And then, of course, there is validation of that. Patients with dementia often experience more rapid progression of disease, increased mortality, morbidity from vector-borne illnesses and non-communicable diseases, frequent exacerbation of pre-existing conditions, worsening grief among caregivers was also a big problem because they're not only mourning the loss of their patients, they also had their own losses. Disaster response is often hindered by, you know, damage to infrastructure, and then food security, displacement, and limited access to medications was also a big issue. So the gaps. We obviously can tell that the research on climate change and palliative care still anecdotal, all descriptive, just people telling their stories in a lot of the literatures. And then the focus had been on just the climate disasters, some of the day-to-day challenges that these patients face in the absence of the big hurricanes and the big storms and so forth aren't published in the literatures. And then studies evaluating the effectiveness of the response programs that I've talked about are very critically in need. So some takeaways. Again, the big question is, what are we doing? What are we doing about climate change? That's why we're here. We definitely need more research to understand the problem and to evaluate the potential interventions, especially as it pertains to our patient population. And we have urgent need to enhance the well-being of care workers, healthcare workers, caregivers like you and I, because not only the people or our patients suffer, a lot of us do suffer during these disasters as well. And then there's strong recommendation for policy change to help us achieve that. A few of the other presenters had talked about this as well. Thank you.